I want to welcome John. I'm going to do this in order from left to right from the video. John, Dana, and Tracy from Behavioral Health of New York City to the presentation, Referral Strategies to Improve Behavioral Health Access and Care. And with that, I'm going to drop off the screen and I will return when it's time for questions.
All right, thank you. So I guess we can kick this off. So good afternoon. My name is John Javis, and I am the CEO of the Behavioral Health New York City IPA. I want to thank you all for coming to our session today. Before we kind of get into the system and how we utilize, I think it was important for us to give, you all the context of behavioral health in New York, and then you'll see, how we arrived at the decision to, purchase the platform. So back in 2014, New York State embarked on a very aggressive DSRIP waiver, about $6.4 billion. And the goal of the waiver was to have 80% of Medicaid managed care dollars be in some form of value-based payment. One of the challenges we have as behavioral health providers is that, hospitals and large primary care practices have infrastructure. They have data infrastructure to support arrangements, and most community behavioral health providers would not. And so to help level the playing field in 2018, New York State provided funding to 18 regional behavioral health networks, and they called it the Behavioral Health Care Collaborative Program, and that's what funds our IPA. And the grant supports the cost of staffing and data and infrastructure related to value-based payment type contracting. Who we are. So we are a network of 10 small community-based behavioral health providers that primarily provide OMH, or mental health and substance use clinics in the New York City area. And when I say small, I mean small. The agencies range in size from 1.3 million. I think our largest is about 12 million. The mission of the agency is to offer rapid access to behavioral health services in the communities and deliver that by culturally competent and linguistically diverse clinicians. So based on the theme that you're hearing, that we look to offer rapid access, the IPA, played off that strength. And that strength is really proven by data. The state does provide us with a database, and there are two measures I want to point out to you. So there's one of the measures that deals with the 7-day mental health follow-ups. This is when the patient is in a psychiatric hospital, they're discharged. Are they seen within 7 days? Our IPA generally does that at an 80% rate. The state rate is 61%, and the city rate is 59%. So you'll see that the IPA far exceeds, the state and the city. Similar for the substance use treatment. There is a HEDIS measure for that, and the IPA, again, hits at 85% in comparison to 78% for the state and 75% for the city. We all know that in New York and probably around the country, there's a workforce shortage for behavioral health, but our agencies do try to prioritize referrals from higher levels of care, such as hospitals. In terms of who we serve, the IPA serves about 12,000 patients. About 70 of those are Medicaid patients. 30% are other payers. Not sure if this is the case for the rest of the country, but in New York, Medicaid is actually the best payer for behavioral health, and commercial contracts pay the lowest. And for hospitals and primary care, it's the exact opposite. So for them, commercial is the highest payer and Medicaid is the lowest payer. And so that can create tension in referrals sometimes. Our IPA also serves a very diverse population, about 1/3 Hispanic, about 1/3 African American, 8% Asian, and 24% white. So why do we come to a need for referral management? So as we form the IPA, and as we were meeting with hospitals and health systems and primary care practices, they would ask us, well, how do I know how to refer to you? You have different agencies, you offer different services, you're located in different boroughs, you take different insurances. How do I know where to refer? And so that's why we looked at some other electronic referral management systems. But we found that by doing that, Referral, or Arista MD as it's known now, was the best system. Other systems we looked at really weren't equipped to handle or safely transfer PHI. They didn't have an algorithm that would kind of, sort and rank the agencies. So again, based on our strength of doing well for rapid access, based on our desire to have one system, one way of referring to the IPA, we decided to purchase the Arista MD system. Dana, do you want to take it over and talk about some of the concrete details as to how we did that?
Sure. Hi. So after speaking with external providers, our IPA was in need of a paperless and timely solution, seamlessly aligning the referral process for each of our member agencies that is available 24/7. And Arista MD offered us this solution. We favored that it was free for external users to use, and that straight away patients are kept in the loop by receiving a text message that they will be contacted to schedule an intake appointment. This ability for real-time updates and HIPAA-compliant communication between the patient referral source and the intake coordinators at our member agencies is a real time saver and an excellent organizational tool, eliminating some of those administrative burdens, such as the game of telephone tag, which I'm sure we've all experienced at one point or another. By using Arista MD, our member agencies have been able to accommodate established external partnerships and ensure market share, as it allows for the transfer of referrals to another member agency within our IPA network and limit the leakage to outside providers. So just as a recap of our implementation process, we created a work group by asking our 9 member agencies to be represented by either a clinic director or an intake specialist, so the group can agree on a list of mandatory patient information and specialty questions, and also the type of documentation that they would be requesting based on the type of referring source, such as a hospital, PCP, CBO, and school. Arista MD worked with our team to build an algorithm that would leave the referring source with a list of our member agencies best able to accept the incoming referral, and sorting them by distance in miles from the location of the member agency to the patient's address. This way, the referring provider can factor in which of our member agencies would be most conveniently located for the patient to get to. We later added the option, we added the option for the referral source to send referrals directly to a member agency, which fosters those already established partnerships. We'd like to give a special thanks to John Gouch. He customized our platform by including each and every necessary field and detail that we asked of him, including those that we identified after the initial implementation process. For example, later on, we added a question about whether or not the patient was aware that they were being referred to an outpatient clinic. So we made sure to test and train one-on-one with our selected internal users before going live on May 17, 2021. We then demonstrated the system to several New York health plans, including United Healthcare, Health First, Fidelis, and Empire, who provided us with positive feedback. One of the IPA's main focuses since it's gone live is to keep the platform up to date by making any necessary changes in our already established algorithm. So any configuration issues, such as adding a new location or a newly accepted language, or any change in workflow, licensure, or current capacity. From the analytical feature, we were able to identify the type of facilities frequently sending referrals to our member agencies. And our top referral source type has been hospitals or health system affiliated practices. Secondly, are community-based organizations. And next are government-based agencies. This feature has helped our IPA focus on existing referral relationships, as well as foster new relationships where there is a need. And to date, BHNYC has received roughly 1,000 referrals from about 120 different types of facilities. And next, Tracy will walk you through the theoretical to practical.
Hi, everybody. I think what you heard us saying, we started with why we became who we are as an IPA. And what makes it different for us is our utilization of this Arista Referral platform really was threefold. One was really to make sure that we had this tool to do the job, to make sure that we are able to facilitate referrals from external as well as internal resources. Very pragmatic. We look to be able to do that. But the overarching goal, again, as an IPA, is to make sure that we are aligned amongst ourselves and aligned with our external partners to provide quality care to patients that in the New York City system at the present time can be relatively disparate. There's a lot of work going on behind the scenes that the patient isn't even involved in. We were looking to assure that we had a platform that allowed us to have the communication that was necessary. And because behavioral health has a lot of different external constraints, which I have to share with you, I spent a lot of time on the medical side. This is not treating physician to treating physician. There's consent required. There's more than just scheduling an appointment, which is one of the biggest takeaways for people to hear. In behavioral health, we all want to help our patients. And we are, unfortunately, it's not just HIPAA. It's 42 CFR on the substance use side makes it almost impossible electronically to see different things. So for us, when we were embracing what do we want to do and how do we want to do it, some of it is operational. And the other, to be very clear, this is a marketing, branding activity as well for us. We were brand new to the marketplace. We designed our collaborative. We all had our own existing relationships, each one of our member agencies. And as you heard from John before, they ranged in size. They had a referral base that was previously established. And then here we come in and saying, because of the value-based purchasing component and the accountability for the outcomes that need to be achieved by an IPA, we needed to make sure that we were aligned by operation. We have to make sure that we're aligned by clinical outcomes. And we have to make sure that the experience for the referrers are all aligned. So this platform allows us to be able to make sure that the communication is easy and efficient, that when we were talking to our other provider, external provider referral sources, whether they had existing locations or not, the message clearly was, well, how do we know who to refer to? They already were referring to one agency. But if we had to make sure that each agency takes the insurance and they make sure that they have linguistically competent clinicians, we needed to make sure that all of those things were clear in that referral so there was no delay. For those of you that are coming from health systems or doctor's offices, we're very aware everybody wants feedback within 24 hours. We're using this system not only for scheduling, but to make sure that the clinical assessment can be done before that improves. The difference in behavioral health referrals is you can't just look at a template like a ZocDoc and make the appointment. There has to be some sort of clinical assessment to assuring that the patient that is being referred and is not necessarily part of that process is involved enough to make sure that we have the appropriate referral for the appropriate patient at the appropriate time. Behavioral health referrals, and I'm not taking this lightly, for most of you that are in the medical field, we all know that motivation to assure somebody's health is a very individual thing. In behavioral health, that's even more so. A doctor can see somebody and say, are they defining that they have a substance use problem? They might be a little depressed after the last 2.5 years. Aren't we all struggling with the anxiety that has been predicated on the fact that we're living through a pandemic? I can tell you that all of the challenges people have had, everybody is experiencing some level. Where does that become pathological? That may be subjective to the referring person. So in behavioral health, you want to make sure that person is prepared to deal with their discomfort in that sort of therapeutic situation without just going through all of this process and then the patient's not going to show up. The last most important component to the referral program in behavioral health that I have to share with you, I think is a little different than in other disciplines, is the fact that there is a clinical evaluation required before we do any scheduling. The additional component in New York, and one of the reasons we were funded, is the fact that outcome measured, patient outcomes that are being measured is relatively new for our field. It's been around a longer time between Medicare And in the medical field, they're looking at some of those things for us to educate our providers and get them used to not only dealing with data, right? They have to understand what this means in terms of how they're perceived by the managed care plans. It's a new language. People like me that have been practicing a long time, we talk about patients, we talk about clinical outcomes. We're not necessarily as adept at talking about data. And I think one of the roles for our IPA has been educating our people to do that. This system has allowed us to not only be efficient, but we can also look at and evaluate through the data analytics side of this, all of the information, because it's all stored in one place. The challenge for us in terms of the managed care plans is that they really want certain things that, in all honesty, we're struggling significantly with workforce shortages. It is a national problem, and people think, oh, in New York, you have more people available. That is not the case. The constraints to say, for Medicare, you have to be a licensed clinical social worker to see somebody and bill. People like that are kind of few and far between. The telehealth parity rules that have come across have been great for our field and really have been able to expand things for us. But we have to be cognizant of the fact that all of what managed care plans want us to do may be complicated based on the fact that we just don't have the resources to do it. In New York City, I can't tell you the diversity, ethnic diversity, gender diversity, but language competence and linguistic competence is really hard for us. Plus the fact that most of our providers, we really do both commercial and public government products. The majority of our IPA are patients that are served by the government products, whether it's, for us, it's called the Essential Plan or Medicaid. And the expectation is different for all these plans. Our agencies have to balance all of those. We need to make sure that our system accounts for all of that, so that, again, we're back to getting the patient to the best provider in the most appropriate time frame. When referrals come in, especially from hospitals, I can tell you they're pressured for discharge. They can send this referral to 16 different places. And the first person that gets back to that referral source may or may not be the best place for them. But we needed to make sure that our process is streamlined, not only for our market share. I'm being very, pragmatic with you to understand that this system helps us to do both. It helps us to be timely. It forces our intake people to respond efficiently, and it makes sure that the appropriate questions are answered. For us in the behavioral health world, the reimbursement varies significantly through, say, Medicare may pay one amount. In New York City, I can tell you, which is, it may be very shocking for some of you, Medicaid is the best payer on the clinic side. So in terms of market share, our agencies can get approximately $170 for a mental health clinic visit in a licensed Article 31 or 32 agency. That is different than a private practitioner. So you have to be aware of that. A private practice provider who is seeing patients doesn't get that reimbursement, but Medicare may only pay $65. So these are challenges for us in terms of balancing our provider base to make sure that we are doing what needs to be done and we can meet our own bottom line. The reimbursement variations truly drive referral patterns, and you have to be realistic with that. We can't survive in our agencies because we're committed and dedicated to the public service side of this, that we have patients that are challenged much more than the old DSM, diagnosis of adjustment disorder. Everybody used to get generalized anxiety disorder. Now we have to make sure that we are seeing people that are part of this SPMI population. Our IPA members see the homeless. They see people that are struggling with housing insufficiency, food insufficiency. Their mental health on top of this is also compromised by health disparities and problems with access to healthcare. So our mental health provider agencies have to make sure that when they're looking at a patient, they can't just segregate out what's the behavioral health problem, because that's not who this entire and whole person is. That's what makes us different than some of the other disciplines. And just, again, not diminishing the fact that every agency has a different experience with their regulatory component. I can share with you as well, in New York State, we are extensively and overly regulated by our state because most of our agencies are dealing with patients that are insured by public dollars. the accountability, the audits, all the rest of that. This is what makes our job harder, and making sure we have a referral program that helps us to do that as easily as possible was absolutely part of our motivating factor in engaging Referral and Arista. With COVID implications, everything shifted literally overnight to telehealth. It was, and I know you've all done the same, and I'm looking forward to hearing some questions about what your experience has been here. The shift for telehealth for our sector has been really something that has been just a paradigm shift. It was always available, but the reimbursement wasn't there. The technology wasn't there. Our folks were using 45 minutes face-to-face in a clinic setting. Once COVID hit, we had to be able to do things very differently. The parity and all of the other regulatory flexibilities that have been afforded at every level really allowed us to stay in business and make sure that our patients at their most needy time still had access to care. Our agencies were reporting that they had a 40% increase in requests for service during the height of COVID. Everybody talks about the fact that behavioral health is become less stigmatized, that there's much more requests for services. At the same time as we struggle with our own workforce capacity issues, we had to make sure that we can accommodate here. And having the fact that there's an electronic platform, when people were not in their offices, they could send emails that are HIPAA 32 CFR compliant, and we can communicate and make sure that there was no delay in access to care. You're looking at this slide. I don't need to do a little bit of, presentation, PowerPoint karaoke with you, but the reality is that the workforce shortage in behavioral health, and I'm sure you will share on your own side, that 97% of the agencies in this sector reported a problem difficulty recruiting staff. This is a national report that was taken, a year ago. 78 even went further to say that they had it very difficult time. So as much as we're trying to do all these things with engaging staff, retaining staff, meeting the demand, making sure that there are enough people that can do what needs to be done, it just adds and mitigates the other set of problems and priorities. We then talked about how do we go about saying, with all of that done, we are dedicated and committed. We are a team. We are also a business organization. Our goal is to make sure that we're doing what we set out to do, what our grant asked us to do, especially in terms of our NCOs. So we try to figure out how are we going to go about making sure that the patients were getting seen that are coming from outside places. This platform allows us to accomplish a variety of very pragmatic tasks in a very efficient way. It allows us to verify insurance coverage and in-network status for patients. Very important, because our referral sources, some of them are a lot more diligent at screening their patients. But if a person's coming from a hospital where they've been 10 times, their insurance may have changed, but that system may not have changed or updated their insurance, and they're sending us something that may or may not have been appropriate. We'll know right away if, when they're putting that information into the system, we will know if the information we're getting is truthful or not. And that really helps us not waste time on patients that may not be in network. John spoke about this. We did a lot of marketing, and then COVID hit, to meet with people, do face-to-face, really talk about branding, to let people know that we exist as a behavioral health collaborative. And they were saying, well, how do I know which agency to send to? This platform allows us, through their algorithm, to route that referral, both if they have an agency they want to be loyal to, they can do that on their own, or the algorithm will then, in fact, default to the agency that can best serve that patient. If some of our agencies have Spanish-speaking providers and then they don't have Spanish-speaking providers because that person maxed out, or just say they had COVID for 2 weeks and they couldn't take any new clients, then in fact, they would be able, for any new referral, to shift that referral to an agency that can in fact accommodate that patient. The adding and the addition of assuring that the patient is aware was pivotal, because as I mentioned before, a provider, whether it's a mental health provider in an inpatient hospital, psychiatric unit, or a community-based primary care provider, They could be seeing a patient. They know this patient will benefit from behavioral health referrals. But how many of you, we get a referral and then the doctor said, oh, you have to go for your colonoscopy. You make the referral to the GI service, and patient said, well, wait a minute, I wasn't really ready to do this, but you went through all of that process. Making sure that the patient is aware allows us to be efficient on our end, and also then do the extra work that might be necessary to engage that patient so they don't dismiss the fact that somebody really felt that working with us would be beneficial to them. The last and one of the other most important parts for us, and what we heard from our referral sources, is we need to maintain an ongoing communication with the referral person to assure that they're getting communication back. That's the carrot. They have to do a little bit more work than just picking up the phone and making a phone call to refer their patient. But if we tell them through the system, we can send them back when that appointment was, and after the fact, when the patient has shown up, that we can give them some of the information that's clinically able to be shared in a HIPAA compliant platform. That has been really something that has worked for us in terms of developing the relationships that we want with our referrers. Because of the fact that COVID hit right after we rolled this out, actually we were in the midst of it to roll it out, we really have to go back to working on re-engaging our referral sources and expanding them. Because again, I've said before, we're a business model. There's plenty of need, there's an increased need, but we need to go back to make sure that we have the kind of relationships that are gonna help our members stay in business and make sure that the patients are getting the help that they need. As the need arises and our folks are getting more creative in how to do their work, that's the next step for us to talk about that. We also need to do a little bit more promotion, not only with the agencies, but for us, sharing with you our social media presence has not been as wide as maybe we would like it to be, but nobody could really talk about expanding during COVID, but now that messaging might be a little bit easier. Use of data for our folks. We have done a lot of work internally at getting the behavioral health field up on understanding and talking the talk the way the plans talk it, the way our other external providers are looking at how our performance is judged. We need to do and incorporate that data analytic capability within our metrics and our performances. We've done very well on some, maybe not so much on others, but our success is going to be based on how we continue to grow in that area. So our next step is to continue to build upon the conversation and the comfort level of our providers around using metrics to monitor care. We are also talking about doing some patient-client satisfaction, because not only do we can say we think this is great, we've got anecdotal responses from people that thought it was great, but we want to do a formalized client satisfaction survey, both internally and externally. We've been constantly reevaluating based on the fact that our people are not shy and sharing with us what has worked and what hasn't. But we're really looking to do a much broader client satisfaction survey for everybody to make sure that we can really move this forward. And in terms of establishing a best practice, I told you before we wanted to talk about internal alignment. We've been working on those systems as well. We did come up with these questions, as Dana referenced for you. We had a user group to make sure that we adapted the referral system with John Gouch's assistance to really bring in what we thought was a little different for behavioral health folks. So we wanted to make sure that the system really can deal with those sorts of referrals in the best way possible. And we want to build that out so all our people are approaching intake the same way. We have at least established some of those categories, but in terms of how they process things, that's the next step for us as well. So, I really wanted to have a little bit more of a conversation with you. We talked about the system. It's worked for us. We want to build it out even further. But, for your experience, both as medical providers or other behavioral health providers, we can share with you what our experience has been, how we want to move this forward, and how this tool has really helped us to meet the goals that we've established for ourselves. So thank you for listening, and we really welcome any of your questions.